All right, you guys excited? Because I know I am. This is a this is a topic that's near and dear to my heart. I love talking about allergy and immunology, and I want to share with you some clinical pearls that you guys are going to ace the allergy and immunology portion of your pediatric board examination. So why is allergy and immunology important to you guys? It's important to you guys because the American Board of Pediatrics thinks it's important. About 3.5% of your questions are going to pertain to allergy and immunology, right? Now, 3.5% may not seem like a lot, but if you compare that to other specialties like GI or endocrine, it's roughly equivalent, 3.5%. That's more than cardiology, that's more than renal. The only subject that has a higher question content is growth and development. So you really got to know your allergy immunology and also know your developmental milestones as well too. Okay, so what I'm going to do today is I'm going to go over immunology and also allergy as well too. And before I do that, I want to kind of go over an outline of what we're going to talk about today. First, I'm going to talk about the immune system, because I think it's really important to have an understanding, at least a basic and fundamental understanding of the immune system, okay? Because the boards aren't going to ask you easy questions about primary immunodeficiencies, okay? They're not going to ask you, for example, how do you treat common variable immunodeficiency, or how do you treat Bruton's A gamma-globulinemia? That's way, way too easy. What they're going to ask you is they're going to give you a case, a scenario, of a child who presents with multiple infections, sometimes opportunistic infections, other times recurrent infections. And what you're going to have to do is you're going to have to go backwards and try to figure out which arm of the immune system is affected. Is it your T cells? Is it your B cells? Is it a problem with complement? Is it a problem with phagocytes? And in order to do so, you really need a sort of a basic fundamental understanding of the immune system. And that's what we'll do today, is to kind of give you that basic knowledge. Okay? I'll go over both the innate immune system and the adaptive immune system. We'll sort of talk about some of the players involved in the immune system, certain cells that are involved. We'll talk about the paradigm of immunology, that is MHC restriction or HLA restriction. I'll talk about antibodies and their roles in fighting off infection. We'll talk about complement cascades as well too. And then using that knowledge today, we'll talk about primary immunodeficiencies and how you diagnose and manage a child with primary immunodeficiency. We'll talk about both combined immunodeficiencies with both T and B cell defects, separate B cell defects, phagocyte abnormalities, and also complement deficiencies as well. Then we'll take a little bit of a break afterwards. And then after you come back from the break, we'll talk about allergies. We'll discuss the different types of allergic reactions based on the Gell and Coombs classification, type 1, 2, 3, and 4 hypersensitivity reactions. And then I'll go on to specific allergic disorders like anaphylaxis, urticaria, angioedema. I'll touch a little bit on asthma because as an allergist, I don't think I'd be replete without talking or spending a few minutes on asthma. But Dr. Jones has a fabulous section on pulmonary medicine, which she'll have on Saturday. So she'll go into much more detail than I will about asthma. But at least I wanted to touch base a little bit about asthma. Then I'll talk about allergic rhinitis, atopic dermatitis, food allergies, adverse drug reactions, insect and latex allergy, and then I'll end up with some discussion about immunological disorders such as mastocytosis and serum sickness. All right, so first let's talk about the immune system. Okay, so classically the immune system has been divided into the innate versus the adaptive immune system. The innate immune system is very rapid acting, it's not very specific, and it doesn't induce memory. Okay, so it's sort of your basic immune defense against organisms. Okay, it's much less advanced than the adaptive immune system. Evolutionarily, it's started off much earlier. Some of the key players in the innate immune system include complement, macrophages, and natural killer cells. The adaptive immune system, however, is much slower to respond. However, it is very specific, and it can induce memory. So once your immune system sees that organism, fights it off, and that pathogen later on comes back, it can remember that it's been attacked by that pathogen and mount a much quicker response. So that's the whole concept of memory. So some of the players in the adaptive immune system include your humoral arm, which include B cells, your plasma cells, and your immunoglobulins or antibodies. And then you've got your cell-mediated arm, which include T cells, activated macrophages, and activated natural killer cells. Okay. So what's the difference between the innate and adaptive immune system, and why are they different? Well, the difference really lies in the receptors that they use. So for example, the innate immune system uses these generic, ready-made receptors. So an example of that would be for your toll-like receptor. So for example, toll-like receptor 4 on macrophages within the innate immune system can recognize lipopolysaccharides, okay? And so now it can sense gram-negative bacteria. But it's very generic because it can just tell you, well, it's being attacked by gram-negative bacteria, and can't tell you specifically which one it's being attacked by. Is it Serratia? Is it E. coli? Is it Enterobacter? Is it Pseudomonas, for example? The toll-like receptors, or your ready-made receptors, allow for a quick but very nonspecific response to invading pathogens. In contrast, the adaptive immune system has these very custom-made specific receptors. So for example, your T cell receptors and your B cell receptors are very refined, they're very specific, and they recognize an almost infinite variety of different pathogens. So from the time that you're born, you're able to fight off almost every single pathogen out there, which is pretty amazing. Now, there's a lot of communication between the innate and adaptive immune system. So the innate immune system, you can sort of think of them as your first responders in an attack. They come into the picture right away to kind of take care of the infection. And they do this by being able to recognize some common features of a group of pathogen. So like I mentioned before, your toll-like receptor 4 on your innate macrophages allow for recognition of your gram-negative bacteria. So once it recognizes a gram-negative bacteria, then it sends signals to your adaptive immune system to come in and respond and sort of mount a more specific, more robust defense. Okay? So as an example, you've got your macrophages, like I said. These are part of the innate immune system. They come in and they may see a bacteria. If it's gram-negatives, perhaps they have toll-like receptors on them. They engulf the bacteria and then provide signals to activate the adaptive immune system arm, which include, for example, T cells. Right. Now, there's a lot of overlap between the two. We sort of kind of distinguish between the two, but there is quite a bit of overlap. So, for example, some cells, such as macrophages and natural killer cells, may initially function as part of the innate immune system, but they may be later activated by T cells and then become part of the adaptive immune system. So there's a lot of crosstalk between the two, and there's a lot of overlap between the two as well, too. Okay. And then there's also these innate-like cells. These cells are kind of like your hybrid cells. They're part of the adaptive immune system, but they sort of function like innate cells, meaning that they're much rapidly acting. They're more rapidly acting, but they're less specific than your true adaptive cells. So some examples of these include your delta gamma T cells. These are your T cells that sort of line the gut. Okay, you've got your natural killer T cells, which I'll talk in more detail about a little bit later. You've got your B1 cells. Your B1 cells are like your innate-like version of your conventional B cells, which are your B2 cells. These cells are found in your peritoneum, and they're also found in the pleural space. And they mount a much quicker response than your traditional B cells. And then you also have got your marginal B cells, which are found in your spleen. And again, they mount a much quicker response than your traditional B cells. Okay. So let's talk about some of the players of the immune system. I talked about some of them already. You can divide the immune system into your lymphoid cells and your myeloid cells. Your lymphocytes include your B cells. We talked about your B1 cells a little bit. B2 cells are your conventional B cells, and then your marginal B cells, which are in the spleen. You've got your T cells. So you've got your traditional alpha-beta T cells. Examples of these include your cytotoxic T cells or your CD8 T cells, your helper T cells or CD4 T cells. You've got your sort of hybrid innate-like cells, your delta gamma T cells, which are found primarily in the gut. And then you've got your natural killer T cells as well. And then within that lymphoid group, you've got your natural killer cells. And on the other side, you've got your myeloid cells, which include granulocytes, neutrophils, eosinophils, basophils, monophils, macrophages, mast cells, erythrocytes, and platelets. Okay? All right. So this is kind of a schematic of, you know, the players that are involved in your immune system, right? So if you were to sort of list out which ones are part of the innate immune system and which ones are part of your adaptive immune system, your innate immune system includes your natural killer cells, your granulocytes, macrophages, and dendritic cells. And you've got your adaptive cells, which include some of your B cells, your T cells. And then finally, you've got your sort of hybrid innate-like cells, which are your B1 cells, your delta gamma T cells, and also your natural killer T cells. Okay. So let's just take a step back. Now, immunology gets really, really confusing because there's a lot of alphabet soup. A lot of times we talk about CD this, CD that, IL this, IL that. And a lot of times when I talk about IL this, IL that, most people say, well, I'll see you later, okay? So just to kind of, you know, make things more understandable, let's talk about what these actually mean. What are ILs and what are CDs? Well, CD stands for clusters of differentiation. What are they? What are CDs? Well, they're basically just name tags on cells, right? It allows us to recognize what type of cells they are, right? So we've all heard about helper T cells, right? So they're CD4 cells are your helper T cells. Your CD8 T cells are your cytotoxic T cells. Your CD56 are your natural killer T cells. So these are name tags on immune cells that allow us to recognize what they are and what their function is. What about ILs or interleukins? Well, these are the language of immune cells, okay? They're secreted by one cell to tell another cell what to do, right? It's kind of their communication, right? So if you've got an invading organism like Mycobacterium, for example, right, your cells are going to produce IL-12 because to them, IL-12 means we're being attacked by probably Mycobacteria, okay? So it's just the language of your immune cells. Right? Now this brings us to the sort of the paradigm of immunology, which is MHC restriction or HLA restriction. And basically what HLA restriction does, it allows the body to recognize self from non-self material. So this is really, really important because you want to distinguish between, is this a foreign pathogen or is this your own self, okay? And the human MHC is called HLA, or human lymphocyte antigen, and it's located on chromosome 6. There's 3 classes, HLA1, HLA2, and HLA3, and I'll talk about each of those. Okay? So HLA1, right? These HLAs are on almost every single cell in your body, except for mature red blood cells, okay? And the concept of MHC restriction is that your cytotoxic T cells can only recognize antigen when it's presented by an HLA1 molecule. Okay, so all the cells in your body, all right, are going to present its self-protein on the surface. So these CD8 T cells come along and recognize that peptide or that protein in the context of an MHC1 molecule and say, okay, this cell's okay, its machinery, it's working, the cytotoxic T cell sort of moves on. If you have a virus, for example, take over that machinery, it's going to replicate and take over the machinery of that cell, and now the viral proteins are going to be on the cell surface. So when that happens, the cytotoxic T cell can come by, it recognizes the HLA1 molecule and the viral protein, says, hey, something's going on, the cell is compromised, it's been taken over by viral machinery, we need to destroy it. Okay, so that's the whole purpose of this. All right, so there you have it. You have any cell, it presents its own internal antigen within the context of an MHC1 molecule, the cytotoxic T cell, that CD8, remember that name tag, CD8 T cell with its T cell receptor goes by, recognizes the self-antigen and also the MHC1 molecule. Now what about MHC2 or class 2 antigens? All right, so these are only found in antigen-presenting cells. Antigen-presenting cells are cells that go and gulp up other material, okay? So these include macrophages, monocytes, dendritic cells, Langerhans cells, your B cells, and helper T cells can only recognize antigen when it's presented in the context of an MHC2 molecule. Okay, so what you have is you have these macrophages, and they gulp up, material, whether it be, any kind of material out there, and it presents it in the context of an MHC2 molecule. So your helper T cell comes by with its T cell receptor, and it recognizes your MHC2 with your CD4 receptor, and is able to recognize that antigen. Okay. So to summarize, HLA restriction really is you got your cytotoxic T cells can only recognize antigen when it's presented in the context of a class 1 HLA antigen. Your CD4 helper T cells can only recognize antigen when it's presented in the context of a class 2 antigen. So a nice way to remember this, 8 times 1 is 8, 4 times 2 is 8, and 8 is great. Stupid, but easy to remember. Okay? All right, so there you have it right there. The whole premise and paradigm of the immune system. All right, so let's move on and talk about T cells. All right, what do T cells do? What's their function? Well, the function of T cells is really twofold. One, T cells destroy intracellular organisms, okay? And they also help regulate antibody production by sending signals to B cells, all right? So your T cell receptor, all right, is part of the adaptive immune system, and it can recognize almost an infinite variety of different protein antigens. And of course, because of that restriction, it has to be presented in the context of an MHC molecule. And all T cell receptors have to carry along with it something called CD3. The reason being for this is the T cell receptor needs signal transduction, and only the CD3 molecule can carry that signal transduction. Okay, so all T cells have this CD3 on the surface. All right. So now different subsets of T cells, your helper T cells, your CD4 T cells, these are important against extracellular pathogens. There's 2 different subsets, your Th1 subset. These Th1 subsets can induce cytotoxic T cells and lead to cell-mediated immunity. Your Th2 subsets can induce B cells to produce antibody and provoke a humoral immune response. Your cytotoxic T cells are really important for defense against intracellular pathogens and also cancer surveillance as well too. Right? They can recognize cells that have become neoplastic. All right, what about natural killer T cells? Our natural killer T cells, and why are they called natural killer T cells? Well, they're called natural killer T cells because they're a little bit different than your regular T cells. Instead of peptides, they recognize lipids and also glycolipids. Now, they're similar to T cells in that they also have to be presented in the context of an MHC-like molecule. In this case, it's CD1. Okay? Remember, the T cells recognize proteins only in the context, also in the context of an MHC-like molecule. Okay? Now, these natural killer T cells, as I mentioned earlier, are innate-like. Why are they called natural killer T cells? Well, because they have on their cell surface CD16 and CD56, right? Those name tags, okay? So that's why they're called natural killer T cells. Now, there's something called T regulatory cells, right? So why are they important? Well, after a pathogen has been contained, all right, you need to suppress the immune system because you can't keep on having the immune system go on and on and on and on and have continuous inflammation. You got to turn on the switch, and now you've got to turn off the switch. So the function of T regulatory cells is to suppress and regulate the immune system. And they do this by secreting regulatory cytokines like IL-10 and TGF-beta. So these ILs are immune speak for suppress. So they tell the immune system, hey, we've already contained the infection. It's time to turn it down a bit, okay? So they're going to produce IL-10 and TGF-beta to sort of suppress the immune system. The expression of T regulatory cells is really controlled by a transcription factor called FOXP3. It really regulates the development and the function of T regulatory cells. And why is this important? Because if you've got mutations or an absence of this FOXP3, you can actually get an autoimmune syndrome called IPEX. And IPEX is really easy to remember. All it is just a mnemonic for immune dysregulation polyendocrinopathy, X-linked, and that's it. IPEX. Okay, so when you don't have this FOXP3, it causes this IPEX syndrome, and these kids have autoimmune endocrinopathies, immune dysregulation, and whatnot. Okay. Now, natural killer cells, right? Natural killer cells are really responsible for fighting off tumors and viruses. Okay, they express CD16 and CD56. That's why they're called natural killer cells. And why have they come into existence? Well, remember I told you before that the CD8 T cells can go around surveilling your own cells to see if it's been overtaken by viruses, right? And most of the time it's very effective because it can recognize that the virus has taken over the cell's internal machinery. Now the virus has started to produce its own viral proteins on the cell surface. Cytotoxic T cell can sort of recognize that and then kill off that infected cell. Well, viruses have gotten very smart as well too. In order to survive, what they've done is they've reduced that MHC or HLA expression. So now what you've got is you've got a bare cell which has no viral peptides on the cell surface. So the CD8 cytotoxic T cell can't recognize it, and it just kind of moves on its way and does nothing about it. And then the virus just starts replicating, and infecting more cells. Well, as a counter to that, the immune system has produced natural killer cells. These natural killer cells are always sort of in this kill mode, all right? So in order for it to not kill, the cells have to have on its surface something called HLA-E. It's kind of like a security badge, right? So it goes around looking for the security badge, is HLA-E. And if you don't have it, the natural killer cell is going to kill off that cell. So it's a nice way of sort of circumventing how viruses have adapted to the immune system. What about B cells? What do B cells do? Right? So B cells, as you all know, produce antibodies. Okay, but they can also present antigens as part of antigen-presenting cells, and they present protein antigens, your CD4 helper T cells. Some few words about antibodies. They're composed of 2 heavy chains and 2 light chains. You've got 5 isotypes: IgM, IgD, IgG, IgE, and IgA. And we'll talk about each of one of those in a little bit. What's the function of antibodies? Well, they opsonize organisms. What does that mean? They basically coat the organism, all right, and then sort of signal it for destruction. They can also neutralize viral particles, toxins as well too. And then lastly, they can activate complement. So this is the antibody structure of a typical IgG molecule, excuse me. You've got your heavy chain, and right here, let me see, right there. You've got your light chain right here. All right, this is the variable region. This is where the antibody binds. You've got your FC portion, which sort of distinguishes whether it's IgG, IgM, IgE, or IgA. So IgG is the main antibody in the serum. It's the major antibody in the immune response. There's 4 subclasses of IgG: IgG1, IgG2, IgG3, and IgG4. It readily crosses placenta, so it provides protection for the fetus and the baby after birth. So does anybody know why most children start having infections when they're about 4 to 6 months of age? Well, the reason being for that is that's where the maternal antibodies start to wane. Okay, the baby is not able to start producing antibodies very efficiently yet, and the maternal antibodies start to wane. That's why you start having otitis media at about 4 to 6 months of age. The mother is so efficient at actively transporting her IgG antibodies that when the baby is born, the baby's IgG levels are actually higher than the mother's. So at the 3rd trimester, you've got this actual active transport of IgG antibodies through the placenta into the fetus, so that you have a lot of IgG antibodies present at birth. Okay. The other thing that IgG can do is it can activate complement as well. Okay. IgM is the first immunoglobulin produced in an infection. So it's very helpful to distinguish between acute infections versus chronic infections. And it's secreted as a pentamer, meaning that there's 5 of these immunoglobulins joined together by a J chain. So because there's so many of them in one structure, it's the best antibody for complement activation. So basically this is what IgM looks like. It's 5 immunoglobulins joined together by a J chain, and so that's why it's very effective for complement activation. IgA is the main immunoglobulin in secretions, so it's very important for mucosal defense. It's secreted as a dimer, so that you've got 2 immunoglobulins that are joined together by a J chain and a secretory component. That secretory component may be a piece of epithelial or liver cell receptor, and it's secreted in breast milk. All right. So does anybody know why dogs lick their puppies and mothers kiss their babies? Well, the reason why dogs lick their babies is because she's actually doing immune surveillance. She's licking her baby so that her immune system can survey the pathogens on the baby and then produce IgA antibodies to secrete into the breast milk. So that's why puppies lick their babies and mommies kiss their babies. Okay? IgA is not a very good complement activator, right? Kind of makes sense, because where's IgA located? It's in the gut. It's in the mucosa. What is also in the gut? You've got all kinds of bacteria in the gut, whether it be commensal or pathogenic. You've also got these food antigens also in the gut as well, too. So you can imagine if you've got complement activation in the gut, it would be pretty horrible. So that's why IgA does not activate complement. So this is what IgA looks like. It's 2 immunoglobulins attached together by a J chain. Now IgE is the lowest, has the lowest concentration in the serum, right? And depending who you ask, it could be the bane of existence for allergists, or I think of it as it keeps us in business. So, all right, so I'm happy for IgE. But IgE wasn't always just used to, cause allergies for people. It actually had a purpose, right? IgE fights off parasitic infections. So before we had, clean living conditions, sanitary conditions, there was all these parasites going around, right? So, and still in third world countries, IgE and eosinophils are extremely important in fighting off parasitic infections. I'll touch a little bit on the complement pathways. There's really 3 pathways: the classical pathway, the mannose binding pathway, and the alternative pathway. I won't go through too much of the details, but just know that they kind of converge together at this C3A, and then C3A causes C5b, C6, C7, C8, and C9 to kind of join together to cause this MAC complex, or membrane attack complex. And what the membrane attack complex does is it sort of pokes holes in bacterial cell walls and causes lysis of the bacteria. So now with that sort of basic, fundamental understanding of the immune system, we'll go on and talk about primary immunodeficiencies. Okay? There's over 150 described immunodeficiencies, and I can't talk about all of them, but I'll talk about some of the most common ones. Okay? And plus, there's more being discovered every single day. But based on what we know now about, how to evaluate for immune systems defects, I'll talk about problems that arise through problems with the adaptive immune system, the innate immune system. I'll talk about combined T and B cell deficiencies, T cell deficiencies, B cell deficiencies, and we'll talk about other innate problems like phagocyte disorders, toll-like receptor disorders, and complement defects. So let's start off with T-cell deficiencies, right? So patients who have T-cell defects, what kind of organisms are they susceptible to? And what kind of infections do they get? Well, they get infections with intracellular organisms and opportunistic infections. So for example, Salmonella, syphilis, mycobacteria, MTB, MAC, MAI, viral infections like CMV, HSV, EBV, fungi like Candida, Aspergillus, Cocci, Cryptococcus, Hyptoplasmosis, PCP, isosporidias, and also microsporidiasis. Okay? So these are the organisms that patients with T-cell defects will commonly be susceptible to. And so, does it sort of ring a bell? What's the analogy to patients that get HIV, for example, right? So HIV patients get very similar infections, okay, to these patients with T-cell defects, right? Your HIV or AIDS patients will get syphilis, they'll get MTB, they'll get CMV retinitis, CMV colitis, they'll get candidal infections, cocci, crypto, PCP is very common in your HIV/AIDS population, toxoplasmosis, right? And that's because HIV is really the sort of prototypical acquired T-cell deficiency. Now you've got your congenital T-cell deficiency. So as a matter of fact, when HIV/AIDS came along in the scene, early on, a lot of immunologists started treating HIV and AIDS patients because they were getting sort of the same infections as their patients with T-cell defects. Okay, so if you kind of think about, what do patients with HIV get? Sort of your acquired infections, and then you can kind of relay that back into your congenital T-cell defect patients. All right, what about B-cell deficiency? What do these patients get? So patients with B-cell defects get recurrent sinopulmonary infections. They have a lot of problems with encapsulated organisms, okay? Why is that? Because they've got no IgG and IgM to coat that encapsulated cell wall. So you're going to be susceptible to strep pneumo, H. flu, Staph aureus. They'll have also problems with enterovirus and giardia because they don't make any IgA or IgE, or they don't make functional IgA or IgE. What about your combined T and B cell defect? All right, what do they get? Everything. They get everything under the sun. So you've got T cell problems, you got B cell problems. They pretty much get everything. Okay. What about patients with phagocyte disorders? What do they get? Well, they get skin and organ abscesses, particularly with catalase-positive organisms like Staph aureus, Serratia, Aspergillus, Chromobacterium. Anytime you've got a patient who's growing Chromobacterium in their blood, you really want to think about a phagocytic disorder. They also get problems with Burkholderia and also nocardia as well, too. Right. What about complement deficiency? What do these patients get? A lot of times they get overwhelming sepsis. If it's early complement, they'll have pyogenic infections and also be susceptible to autoimmune diseases. What about and patients with late complement will be susceptible to Neisseria meningitis. Okay, so with that in mind, I'm going to talk about the individual primary immunodeficiencies. We'll start off with combined B and T cell deficiencies. We'll talk about SCID, Wiskott-Aldrich syndrome, ataxia, telangiectasias, Bloom syndrome, and Megan breakage syndrome. All right. So first of all, severe combined immunodeficiency, or SCID, there's a host of different ones. There's different genetic causes of these different SCIDs. The most common one is your IL-2 receptor gamma defect. The next most common one is your ADA deficiency, so I'll really focus on those two because they're the most common. So how do infants with SCIDs present? Well, they present within the first few months of life. All right? They're really, really sick. They've got this eczematous-like lesions. They get chronic lung disease, chronic diarrhea, failure to thrive, sepsis. If you do an X-ray on them, there's an absent thymic shadow. You've got severe lymphopenia, and they're pretty sick. So if you've got a child that has suspected SCIDs, it's really a medical emergency. All right, so what do these children or infants get? Well, they pretty much get everything. They've got problems with intracellular organisms, opportunistic infections, and also recurrent sinopulmonary infections as well too. So they get really, really sick with pretty much everything. All right. So the most common SCID is your X-linked SCID. This is due to a defect in your IL-2 receptor gamma. Okay. It occurs in about 50% of all cases of SCID. if you were to do flow cytometry for these infants, they wouldn't have any T cells. They would have B cells present, but they wouldn't be functioning, and there wouldn't be any natural killer cells present in the periphery. So as I mentioned, it's a mutation in what's called the common gamma chain, and this common gamma chain is used in several interleukins. Remember, interleukins are sort of the language of immune cells. So you can imagine if you're not able to communicate with other immune cells, you're not going to be able to fight off infection, right? So this gamma chain is important in your IL-2, IL-4, and IL-7. So if you don't have this, there's lack of communication within your immune cells, and you're really susceptible to all these bad infections. How do you make the diagnosis? You do molecular analysis, specific looking for your IL-2 receptor gamma defect, and really the treatment is just bone marrow transplantation. The quicker you get these infants transplanted, the better their outcomes. Adenosine deaminase deficiency, this accounts for about 15 to 20% of all cases of SCIDs. If you do flow cytometry in these patients, there'll be no T cells present, no B cells present, no natural killer cells present. This is an autosomal recessive disorder. What does ADA do? Well, ADA really catalyzes the deamination of adenosine to inosine. Basically, when DNA is degraded, you have these sort of metabolites that form. So when you don't have ADA present, you've got these toxic metabolites that form, and so they kill off all your T cells, they kill off all your B cells and your NK cells, so you don't have any present in the periphery. And of course, you can't mount an immune response because you've got none of these cells present to fight off infection. How do you make the diagnosis? Well, you can look at ADA levels in red blood cells, and really treatment of choice is bone marrow transplantation. We've sort of experimented with replacement therapy, enzyme replacement therapy that is, but it's not quite as effective as bone marrow transplantation. Wiskott-Aldrich syndrome, right? A nice mnemonic for Wiskott-Aldrich syndrome is exit, right? So remember, these boys get eczema. It's X-linked, so it's only in boys. There's immunodeficiency and thrombocytopenia. The problem lies in something called the WASP gene, which is it's basically Wiskott-Aldrich syndrome protein, and it's located obviously on the X chromosome. When you evaluate for platelets on the peripheral smear, you'll see small platelets. This is in contrast to other causes of thrombocytopenia where you'll see large platelets. So anytime you have on your clinical vignette that says, small platelets in the face of thrombocytopenia, think about Wiskott-Aldrich syndrome. Okay? Treatment is with bone marrow transplantation, or if that's not possible, you can't find a good donor, prophylactic antibiotics and IVIG. Ataxia telangiectasia, what do these kids get? Well, they get ataxia and they get telangiectasia. Nothing easier than that. The problem is sometimes it doesn't always occur at the same time. And so a lot of kids would just have the ataxia first in the first 2 years of life. They don't get the telangiectasias until later on, 5, 10 years of age, and then they get the immunodeficiency. This is an autosomal recessive disorder, and the problem is with what's called an ATM gene that's responsible for DNA repair. So when you can't repair your DNA, you're at high risk of developing cancer. So these patients are exquisitely susceptible to ionizing radiation, lymphomas, and leukemias. How do you make the diagnosis? Well, if you've got ataxia, you've got telangiectasias, and if you've got an elevated alpha-fetoprotein, you can make the diagnosis of ataxia telangiectasia. So does anybody know why you have an elevated alpha-fetoprotein in these patients? No? Good, because no one knows. Right? No one knows. No one knows why. If you did, you wouldn't be here. You'd be getting a Nobel Prize or something like that. So yeah, nobody knows why they have elevated alpha-fetoprotein. They just do. And there's really nothing else besides like hepatocellular carcinoma, which doesn't really occur in the pediatric population. So if you've got a clinical vignette and it's got elevated alpha-fetoprotein, then really think about ataxia telangiectasia. Bloom syndrome is a chromosomal instability disorder. When you have DNA, it's constantly subjected to mutations. So what the immune system does is it actually breaks it up and repairs that DNA. And in order to put it back together, you have this enzyme called DNA ligase 1. So if you don't have this DNA ligase 1, you're not really able to repair the DNA. And so you can get problems with small stature, telangiectasia, CNS abnormalities, and also immunodeficiencies. And because it's a problem of DNA repair, you get these patients are highly susceptible to ionizing radiation, and they can get leukemias and lymphomas. The Magen breakage syndrome, it's also a problem with DNA repair. The gene defect is in something called NBS1. It produces nibrin, and it's responsible for repairs of double-stranded DNA breaks. Like the Bloom syndrome, it's also autosomal recessive, and patients will have bird-like faces, microcephaly, they can have near-normal IQs, immunodeficiency, and of course, susceptibility to ionizing radiation, leukemias, and lymphomas. All right, so now I'm going to move on to primary T-cell immunodeficiencies. There's not so many primary T-cell immunodeficiencies, and the reason being for that is normal B-cell function really requires T-cell interaction. So if you don't have T-cells functioning properly, you're likely to have a combined immunodeficiency rather than just isolated T-cell immunodeficiency. But some examples of sort of quasi-isolated T-cell immunodeficiencies include DiGeorge syndrome and also Nezlov syndrome. Nezlov syndrome is a thymic dysplasia. As you all know, T-cells are really educated in the thymus, and if you've got problems in the thymus or a lack of a thymus, then you have problems within the T-cell arm of the immune system. So what do patients with T-cell deficiency get? Remember I brought up the HIV analogy. These patients are susceptible to intracellular organisms and opportunistic infections. So they'll get MTB, they'll get CMV, like retinitis, colitis, Candida, aspergillosis, cocci, cryptococcal meningitis, histo. They'll be extremely susceptible to PCP, or now it's called PJP. Toxo and isosporidium, all these kind of opportunistic infections afflict patients with T-cell defects. Now, DiGeorge syndrome, if you recall way back when in your embryology medical school days, the third and fourth branchial arches form the thymus and the parathyroids. So in DiGeorge syndrome, these patients don't have proper formation of the third and fourth branchial arches. So you have problems with having an absent thymus and parathyroid, okay? So these patients, remember I said the thymus is important for T-cell education. So without a thymus, you're going to have T-cell defects. Without a parathyroid gland, you don't produce PTH. You don't have normal calcium regulation. So a lot of these children can present with neonatal seizures due to hypocalcemia. And then there's also a problem with neural migration as well too. So you have facial abnormalities and also congenital heart abnormalities as well too, like VSDs, trichology Fallot, overriding aorta as well too. Most patients, fortunately, with DiGeorge syndrome don't have immunodeficiency, but some can. It's really a spectrum of disease. In what we call complete DiGeorge patients, these patients have severe immunodeficiency and they lack both T and B cell function. Okay. So a nice mnemonic for DiGeorge syndrome, it's catch-22. Right? So you've got your cardiac abnormalities, abnormal facies, thymic hypoplasia or aplasia, cleft lip, cleft palate, hypocalcemia, and it's located, of course, on chromosome 22. Okay. All right, so now I'm going to move on and talk about primary B-cell immunodeficiencies. We'll go over X-linked agammaglobulinemia or Bruton's agammaglobulinemia, CVID or common variable immunodeficiency, specific antibody deficiency, hyper-IgM syndrome, X-linked lymphoproliferative syndrome or Duncan syndrome, and then I'll touch upon transient hypogammaglobulinemia of infancy. All right, so just to sort of recall, what do patients with B-cell defects get? Well, they get recurrent sinopulmonary infections, remember? Because they don't make appropriate antibodies, or the antibodies are not functioning. You've got no IgG or IgM activity, so they're going to be exquisitely susceptible to encapsulated organisms, strep pneumo, H flu, Staph aureus. Because you've got no IgA, no IgE, enteroviral infections, and also Giardia infections. Okay. All right, so X-linked agammaglobulinemia, also known as Bruton's agammaglobulinemia, and the reason why it's called Bruton's is because it's due to a mutation in something called Bruton's tyrosine kinase. And your Bruton's tyrosine kinase is really important for the development of B cells. Without BTK or Bruton's tyrosine kinase, B cells are really arrested in this kind of pre-B cell stage. Okay? And this BTK gene is located on chromosome X, therefore it only occurs in boys. If you were to do flow cytometry for these patients, you'll see that there's no mature B cells present, and because there's no B cells, you can't continue to make antibodies, and of course you've got no antibody response as well too. So working within that, that paradigm that I showed you, these patients with X-linked agammaglobulinemia, they're going to be susceptible to encapsulated organism, strep, H flu, meningococcus, staph, and also to enteroviral infections and Giardia. All right. They get recurrent ear infections, recurrent sinus infections, pneumonias, but they can also get meningitis, sepsis, and also osteomyelitis as well. It usually occurs after 6 months of age because, remember, you still got maternal antibodies going over to the fetus in the 3rd trimester, and so you've got adequate supplies of IgG antibodies in the baby when the baby's born, and then as the maternal antibodies start to wane, the baby's not able to produce any adequate antibodies, and then that's when you start seeing the recurrent infections. Okay. How do you make the diagnosis? Flow cytometry, you've got no B cells, no antibodies, and of course, no antibody function. What do you do for these patients? Well, they don't make antibodies, so you got to give them exogenous antibodies. So that means you got to give them IVIG or subcutaneous immunoglobulins. Depending on severity, you can also give them prophylactic antibiotics as well too. CVID, or common variable immunodeficiency, this can occur at almost any age, but the typical distribution is a bimodal one. Usually occurs about 5 to 10 years of age, and then there's another peak at about 20 to 30 years of age. So what happens in these patients? Well, mature B cells are present, but they're not able to differentiate into plasma cells. So even though in the periphery you can find mature B cells, these patients have low antibody levels, and they certainly have poor antibody response. So again, they'll present with recurrent sinopulmonary infections, with encapsulated bacteria. They have scarring in their lungs. They can get bronchiectasis in their lungs because of these recurrent infections in the lungs. And again, they're susceptible to enterovirus and Giardia infections. Now, the interesting thing about CVID is that they also get sort of like an autoimmune type disease as well, too. They also get a sarcoid-like disease where they have non-caseating granulomas in the spleen, in the liver, and also in the skin as well, too. They can also get a sprue-like illness that causes diarrhea, malabsorption, staturia, and a protein-losing enteropathy. Now, it's really a sprue-like disease rather than true celiac disease because these patients actually don't respond to a gluten-free diet, unfortunately. The patients with CVID, as I discussed, are at increased risk of autoimmune disease, not just with your sarcoid-like disease or sprue-like disease, but also hemolytic anemias, thyroiditis as well too, Crohn's disease, ulcerative colitis as well too. So you might be thinking now, well, wait a minute, we're talking about immunodeficiencies, right? I thought autoimmune disease was a revved up immune problem. It's where your immune system is overly active. So how come these patients with CVID get autoimmune disease? Doesn't really make sense. Well, the reason being for that is you have a dysregulated immune system. You've got a non-functioning immune system. And because these patients are not able to fight off infections and they get recurrent infections, there's persistent inflammation going on, and that really drives the autoimmune disease. So you've got immunodeficiency on one hand, but you also have got autoimmune disease on the other hand as well. Okay? Now, because it's an immune problem, these patients are also at increased risk of lymphomas and cancers as well too. Again, it's a dysregulated immune system. You don't have that normal neoplastic surveillance, and also you're getting recurrent infections, which increases your risk of getting neoplastic diseases. Right. How do you make the diagnosis of CVID? Well, when you do flow cytometry, the B cells are present, but the antibody levels are low. And then when you look at antibody function, it's poor or completely absent. So what do I mean by poor antibody function? Well, what you do is you vaccinate these individuals. You give them like a pneumococcal vaccine, and then you check their response. So they don't have an adequate response, then you can say they have poor antibody function. Okay? So you've got to fulfill all these criteria in order to diagnose someone with common variable immunodeficiency, because a lot of kids will have just low antibody levels, just because. I remember these antibody levels are based on a normal distribution. So there's going to be some people that are going to be on the lower end. You know, by definition, 2.5% of the population is going to be 2 standard deviations below what's considered a normal IgG level. But that doesn't mean that they have common variable immunodeficiency. You've really got to demonstrate that they lack antibody response or function. And once you do, the treatment of choice is to give them exogenous antibodies like IVIG or sub-Q IG. Okay. Specific antibody deficiency. Now for these patients, when you check their flow cytometry, they have normal B cells. You check their antibody levels. They have normal antibody levels. However, you check their antibody response or function, and it's diminished or absent. Okay, so that's what differentiates the two. And so these patients, because their antibodies aren't working appropriately, even though there's good levels, they will get recurrent sinopulmonary infections, again with encapsulated bacteria, and they also have bronchiectasis as well too, plus or minus. How do you make the diagnosis? I already talked about that. Normal B cells, normal antibody levels, but poor antibody response. When you think about it, well, if you've got a patient who's got recurrent infections with sinusitis or otitis media or frequent episodes of pneumonias, you do the test, and if the B cells are there, antibodies are there, but if they got poor function, then you make the diagnosis of specific antibody deficiency, and the treatment's the same. You give them exogenous immunoglobulins like IVIG or sub-Q IG. X-linked hyper-IgM syndrome. This is kind of a peculiar syndrome, and what happens in these patients is they're not able to class switch. So the default antibody that we all make, all right, is IgM. Remember, IgM is the first antibody in an infection. It's sort of your default antibody. Patients with X-linked hyper-IgM syndrome are not able to class switch into the other antibody types, like IgG or IgA. And the reason why they're not able to class switch is because they have something called a CD40 ligand defect. This CD40 ligand is really essential for interactions between T cells and B cells. Remember, B cells need that signal from T cells in order to do what they need to do. So when you don't have this interaction between T cells and B cells, those B cells can only make IgM, they can't class switch, and that causes problems. The second thing that happens for these patients is that the CD40 ligand defect is also important for T cell to macrophage interactions or signaling. So not only are these patients susceptible to sinopulmonary infections because they can't class switch to IgG, they also are susceptible to PCP or PJP now because the T cells are not able to activate macrophages appropriately. So this is kind of a diagram of what happens with B cells and T cells. In order for B cells to class switch and be recognized by your helper T cells, you need your the antigen or peptide presented in the context of an MHC2 molecule with CD4. Remember, 4 and 2, 8. But in addition to that, you got to have the CD40 ligand and CD40 as well. So when you don't have that present, the B cells are not able to be activated, and so you can't class switch from IgM to the other antibody types like IgG and IgA. Okay. How do you make the diagnosis? Well, you do flow cytometry, specifically looking for your CD40 ligand. There's actually, other non-X-linked types where you get CD40 defects as well too, but this is probably as far in terms of detail that you need to know. For these patients, really the way to go is with bone marrow transplantation, and while they're waiting for appropriate donor, you give them exogenous antibodies and also Bactrim for PJP or PCP prophylaxis as well. All right, moving on to X-linked lymphoproliferative syndrome or Duncan syndrome. These patients get overwhelming, near fatal infections of EBV. They get fomentin hepatitis, bone marrow failure, and unfortunately, for those children that do survive, a few years later, they get lymphoma. For whatever reason, EBV sort of triggers a polyclonal expansion of B cells, and they get lymphomas. We know that the defect is due to something called an SH2D1A gene, which when it occurs, it causes these patients to be exquisitely susceptible to EBV and also susceptible to lymphomas as well. Transient hypogammaglobulinemia of infancy. Now, this really is a diagnosis of exclusion. And the reason why I say it's a diagnosis of exclusion is you got to want to rule out all those other primary immunodeficiencies first before you label a child as transient hypogammaglobulinemia of infancy. So you really got to follow these kids for a long time. What happens in these kids is really it's a normal variant or abnormal prolongation of that nadir. Remember I said that you've got that antibody nadir at about 4 to 6 months of age. When the maternal antibodies are used up, the half-life of IgG is about 3 weeks. So after about 4 or 5 half-lives, or 4 to 6 months, you lose all the maternal antibodies. And for these infants, they don't start producing their own IgG. And that's when you continue to have this sort of persistent nadir. Most of these kids do fine. By the time they're 4 years of age, they're able to produce their own IgG antibodies, but you really have to follow them for that long to make sure this is the diagnosis and not something else. Okay? Although their IgG levels are low, they don't have a problem mounting a response. So their antibody function is actually pretty good. Okay. So I know I sort of put a lot of information there for you, and it can get sort of confusing with all these different primary B cell immunodeficiencies. So I like to kind of go over them. So when you have a question on the boards, the first thing you want to do is you want to figure out, well, which arm of the immune system is affected. So if the patient has recurrent sinopulmonary infections, and they're getting a lot of problems of encapsulated organisms, or they're getting enterovirus infections or Giardia infections, you want to say, well, this sounds like a B cell defect. And then you want to ask yourself, are there, is it a qualitative defect or is it a quantitative defect? Are there B cells present? Okay? If there's no B cells present, all right, then it's X-linked A-gamma globulinemia. Those patients don't have B cells, so they don't make antibodies, and of course they don't have any antibody response. If it's common variable immunodeficiency, these patients have B cells present. The antibody levels, however, are low, but they don't have antibody function. If it's specific antibody deficiency, it's really, really sad, but they are susceptible to infection, right? They've got normal B cells, they've got normal antibody levels, but unfortunately, they don't have an antibody response, okay? Hyper IgM syndrome, they've got the B cells because that's not the problem. The problem, remember, is class switching. So if you've got a lot of IgM present, but you can't class switch to IgG or IgA or IgE, so they can't form an antibody response. And the treatment is bone marrow transplantation because not only are they susceptible to sinopulmonary infections, but they're also susceptible to some opportunistic infections like PJP, because that defect also causes problems with T cell and macrophage interaction. So you really need bone marrow transplantation. And then lastly, transient hypogammaglobulinemia of infancy. You've got normal B cells, you've got low antibodies, but they've got pretty good antibody function, antibody response, so you just kind of observe these kids. Okay? All right. So now we're going to move on to phagocyte disorders. Okay? I'm going to talk about the different types of congenital neutropenias, including Kosman syndrome, severe chronic neutropenia, or cyclic neutropenia. We'll go over chemotaxis defects like leukocyte adhesion defects, and then we'll finish off with some killing defects like Job syndrome, Shirei Higashi, chronic granulomatous disease, and specific granule deficiency. All right. So your neutropenias, you've got your Kosman syndrome. All right. Now, Kosman syndrome was actually described more than 50 years ago, back in like 1956. Only recently we found out that the mutation is due to something called the HAX1 gene. It's an autosomal recessive condition. This is in contrast to severe chronic neutropenia. It's autosomal dominant, and it's due to a mutation in neutrophil elastase. Now, cyclic neutropenia, it's also autosomal dominant, but the absolute neutrophil count sort of cycles. So every 3 to 6 weeks, you'll have your nadir of neutropenia, and that's when these patients tend to have problems. It's also due to a mutation in neutrophil elastase. No one really knows why one patient with the same mutation with neutrophil elastase can get either severe chronic neutropenia or cyclic neutropenia. A lot of experts think it's within the same spectrum of disease. Okay. Phagocyte movement disorders or chemotactic disorders, you've got your leukocyte adhesion defect type 1 and type 2. Your type 1 is due to a defect in something called CD18, which is an adhesion molecule. Remember that in order for leukocytes to get to where they want to go, they've got to roll along the blood vessel wall, they've got to stop, and they've got to transmigrate through the blood vessel wall to the area that they're supposed to go to. When this doesn't happen, what you get is you get sterile abscesses. Okay? You can also get delayed separation of the umbilical cord, and you get this profound, severe leukocytosis, sometimes in the 100,000s, because your bone marrow is sensing that it's under attack. There's an infection going on. But these leukocytes aren't going to where they're supposed to go to, so what does the bone marrow do? It just cranks out more and more and more leukocytes. Okay? So you get this really severe leukocytosis. In leukocyte adhesion defect 2, it's due to a defect in fucosylation of this Sil-Lewis moiety that's important for blood typing. These patients, in addition to these sterile abscesses, they also have, poor growth, abnormal facies, mental retardation as well. Now, your phagocyte killing defects include Job syndrome, Shirei Higashi, chronic granulomatous disease, and specific granule deficiency. Now, Job syndrome is really based on the biblical character Job, where Job was really smitten by Satan with all these boils, and so that's really where the name came from. So these patients with Job syndrome, unfortunately, had all these boils all over their body, okay, and that's why it's called Job syndrome. It's also known as hyper-IgE syndrome. The problem of hyper-IgE syndrome is that, although high IgE levels do occur in these patients, it's not necessarily required, and a lot of patients have normal or just slightly high IgE levels. And there's also a lot of other conditions, for example, atopic dermatitis, which will give you very high IgE levels, but won't give you this hyper-IgE syndrome. So what is that syndrome? Well, these patients get recurrent abscesses. They get this severe eczema with boils all over their skin. They get scoliosis, hyperextensibility, delayed eruption of primary teeth. They get fractures. They get recurrent pulmonary infections, which cause pneumatoceles. They sort of have this kind of typical facies. It's kind of coarse, asymmetric, broad nose, prominent forehead, and triangular jaw. Shinya Higashi occurs because there's an impaired lysosome degranulation. It's autosomal recessive. These patients get recurrent skin and sinopulmonary infections. And because lysosomes are also important for pigmentation, your melanocytes use lysosomes. These patients also get oculocutaneous albinism as well, too. Unfortunately, these patients also have some degree of mental retardation. And even though when you do bone marrow transplant for these patients, you may be able to fix the immunodeficiency, you don't fix the progressive peripheral neuropathy. So a lot of these patients, unfortunately, end up wheelchair-bound in their adulthood life. When you do the peripheral smear, what's pathognomonic for Shinya Higashi is you've got these sort of giant granules on your peripheral smear. Chronic granulomatous disease, it's X-linked, or at least it's the most common, X-linked about 70% of cases. And it's really an inability to generate the oxidative or respiratory burst. So these patients will get recurrent organ and skin abscesses. They're really susceptible to catalase-positive organisms like Staph aureus, Serratia, Pocodaria, Aspergillus, Chromobacterium, nocardia. And so because the phagocytes, macrophages, are not able to generate this respiratory killing burst, what happens is these macrophages basically just wall off the infection, and you have what is a granuloma formation. And sometimes these granulomas can cause obstruction as well. So how do you diagnose chronic granulomatous disease? Well, before we used to do what's called the nitro blue tetrazolium test, the NBT test. Basically what you do is you take a sample of the patient's blood, you put NBT on there, it's kind of clear and colorless, and if you've got color change, meaning that there's an oxidative burst present, it changes color from clear to blue. It was very highly subjective, operator dependent. So we've really moved on to what's called the dihydrorhodamine test. And with dihydrorhodamine, you're able to really diagnose the condition. You're also able to identify carriers and autosomal recessive states as well, too. So it's really sort of pushed the NBT test as the test of choice now, the dihydrorhodamine test. What do you do for these patients? Well, you give them prophylactic antibiotics to the susceptible organisms, and also you give them interferon gamma. What interferon gamma does is really revs up the immune system. It really revs up your phagocytes so that it's able to at least kill off some of these organisms that are catalase positive through a sort of a different mechanism. Okay. Specific granule deficiency, very, very rare, but these patients sort of lack primary and secondary granules, which normally fuse when the phagocyte eats up the bacteria, and when this doesn't happen, then you sort of have problems. All right. Now, complement disorders. Now, there's early complement problems and terminal complement problems. So your early complement deficiencies are going to cause pyogenic infections, and these patients are going to have an increased risk of autoimmune disease like lupus-like disease. Your terminal complement deficiency patients are going to have problems with Neisseria meningitis. Okay, complement deficiencies are exceedingly rare, but for some reason the boards love this question. So anytime you have a kid with Neisseria meningitis, always think about terminal complement deficiency. That's going to usually be your answer. Okay, how do you make the diagnosis? Well, you can screen with something called the CH50. All right, it looks for complement activation, and if the CH50 is undetectable, then you can check for the individual factors. Like terminal complement would be C5, C6, C7, C8, and C9. Okay. All right, vaccinations on immunocompromised children. What's contraindicated? Well, all live vaccines, BCG, OPV, MMR, varicella, of course, live intranasal influenza, and smallpox. Okay, so that's what you don't want to give. So this table kind of shows you sort of a broad overview of how to evaluate someone for a suspected primary immunodeficiency. So what you want to do when they give you on the boards that clinical vignette of this child that has multiple infections, you want to think to yourself, which arm of the immune system is being afflicted? Is it the B cell arm? Is it the T cell arm? Is it both T and B cells? Is it phagocytes? Or is it complement? Okay? And once you do that, then you want to think, well, is it a qualitative problem or a quantitative problem? All right, so for example, when you've got your B cell defect, you want to check for a quantitative evaluation first. You want to ask yourself, are there B cells present? Are there antibodies present? And you want to do a qualitative evaluation. What's the antibody response? All right, are antibodies functioning normally? Okay, they won't ask you about your tertiary. That's more for like allergy and immunology fellows. But at least they want you to do is kind of think about where the problem is located and what are the essential evaluations that you should do to evaluate a child with a suspected antibody deficiency. So for another example, your phagocyte defects, if you're thinking a child has multiple cutaneous infections, abscesses, you want to think about chronic granulomatous disease, leukocyte adhesion defect. Look at their CBC. Is there a leukocytosis, a profound leukocytosis? Right? If there is, maybe, and it's in like the 100,000, and there's delayed separation of the umbilical cord, you want to think about leukocyte adhesion defect, and then you can do your flow cytometry for your CD18 defect. Okay. All right. So before I move on to the allergy section, I'm going to talk a little bit about hereditary angioedema. Now, this is not an immunodeficiency per se, but it's due to a problem with continuous complement activation. And where the problem really lies is you have a defect in your C1 esterase inhibitor function. Okay? So without C1 esterase inhibitor, complement continuously is activated, and so these patients get recurrent episodes of angioedema, swelling, abdominal pain, they get swelling in their stomach, extremity swelling, and laryngeal edema, and can sometimes be near fatal. It's autosomal dominant. There's two types. Your type 1 occurs when there's low levels of C1 esterase inhibitor protein. Okay? And of course, because it's low, you've got low function. Type 2 occurs when there's normal levels of C1 esterase. Okay, but that function isn't, that protein isn't working, even though it's present. So it's there, but it's not functioning. These patients, in contrast to your typical run-of-the-mill urticaria and angioedema, these patients do not get urticaria. So on the passage, if the patient has urticaria, it's not hereditary angioedema. You can rule that out right off the bat. Okay, these patients will get something like erythema marginatum, but it's not urticaria. Okay, how do you make the diagnosis? Well,
For hereditary angioedema, you can screen with a C4 level. Remember, it's a problem of constant complement activation. So because complement is being continuously activated, you're going to have low C4 levels. Right? And then after that, you can look at the C1 esterase level and also function as well too. As I mentioned, your type 1, you're going to have both low levels and low function. Your type 2, you're going to have normal levels but low function. Okay. How do you treat hereditary angioedema? Well, up until only a few years ago, you only had two choices, either with attenuated androgens like danazol or aminocaproic acid. What attenuated androgens do is it forces the liver to produce more of the C1 esterase inhibitor protein. But nowadays, we've got a lot of more options. You can replace the missing enzyme with plasma-derived C1 esterase inhibitor protein. There's also bradykinin receptor antagonist that's useful for acute attacks, and also kallikrein inhibitors, which are useful for acute attacks of hereditary angioedema as well. Okay, so let's go over some questions, all right? So pick up your audience response, and we'll go over some questions. The first question is, you've got a 2-month-old boy, comes to your emergency department with respiratory distress, tachypnea, hypoxia. The child is noted to have a dry, scaly rash and is way, way less than the 5th percentile for weight. You do a chest x-ray, there's bilateral hazy infiltrates and an absent thymus. Okay. What is the best test to evaluate this child's diagnosis? Is it A, CH50 with quantitative C3, C4 levels? Is it B, alpha-1 antitrypsin level? Is it C, quantitative IgG subtypes? Is it D, flow cytometry for T and B cells? Is it E, flow cytometry for CD11 and CD18? Okay, very good. Almost all of you got it right. So the answer is D, flow cytometry for T and B cells. What you're suspecting in this child with failure to thrive, absent thymus, infection, is SCID. So you really want to be thinking about SCID in this child. As I mentioned, it is a medical emergency, so you want to get this child diagnosed as quickly as possible and put into a program for bone marrow transplantation. All right, next question. You've got a 4-year-old boy who comes to your clinic, the history of eczema, multiple admissions for pneumonia, and a history of easy bruising. What test can help you confirm the diagnosis? Is it A, dihydrorhodamine test? Is it B, small platelets on peripheral smear? Is it C, C1q inhibitor levels and function? Or is it D, diphtheria vaccine titers? All right, very good. The answer is B. So small platelets on peripheral smear. Remember Wiskott-Aldrich, you got that exit mnemonic, right? So you've got eczema, it's X-linked, it's a boy, immunodeficiency. Okay, so for these, and thrombocytopenia, so anytime you see small platelets on peripheral smear, then really think about Wiskott-Aldrich syndrome. He's easy bruising because he's got low platelets. All right, next question. You've got a 4-year-old boy who comes to your clinic with a history of frequent falls, recurrent pneumonias with multiple admissions, and an elevated alpha-fetoprotein. What is the most likely diagnosis? Is it A, Wiskott-Aldrich Bombay variant? Is it B, ataxia-telangiectasia? Is it C, lymphocyte adhesion defect type 2? Or is it D, Duncan syndrome? Okay, very good. Ataxia telangiectasia, that's the right answer. Okay, so although this child doesn't have telangiectasias yet, sometimes that occurs later. So with this child with recurrent infections, frequent falls, the ataxia, and an elevated alpha-fetoprotein, you can make the diagnosis of ataxia telangiectasia. Question number 4. There's an 8-month-old boy who comes to be evaluated for a history of recurrent otitis media and pneumonia, and a family history of an uncle who had a similar problem who died about 1 year of age. Which of the following tests should be done next in the workup? Should you do A, quantitative immunoglobulins, B, flow cytometry for T cells, C, NBT, or D, chest x-ray to evaluate for the presence of a thymus? Good. Quantitative immunoglobulins. That is the right answer. This is a boy, recurrent infections. There's a family history and the uncle. So you want to look at quantitative immunoglobulins to see if he has Bruton's agammaglobulinemia. Question number 5. You've got a 4-month-old boy who's admitted to the pediatric ICU for PJP pneumonia. The patient is 75 percentile for height and weight. Your initial immune workup shows absent IgG levels, absent IgA levels, and normal IgM levels. What is the most likely diagnosis? Is it severe combined immunodeficiency? Is it B, common variable immunodeficiency? C, specific antibody deficiency? D, hyper IgM syndrome? Or E, X-linked agammaglobulinemia? All right, very good. You guys are doing great. You guys are going to ace this test. So the answer is hyper IgM syndrome, okay? And the reason being for this is this kid has, PCP or PJP pneumonia. It can't class switch, right? So you've got low IgG levels and low IgA levels, but normal or only slightly elevated IgM levels. Now we're going to sort of switch gears and talk about allergic reactions, right? So if you follow the Jelen-Coombs classification for allergic reactions, there's type 1, type 2, type 3, and type 4 reactions. When you talk about type 1 reactions, these are your immediate hypersensitivity reactions. These are reactions that are going to occur right away. It's going to occur within a few minutes to the latest a few hours after the trigger. It's IgE mediated. Your type 2 reactions are your cytotoxic reactions. These are IgM or IgG-mediated reactions. Your type 3 reactions are caused by antibody-antigen complex deposition. Your type 4 are your delayed reactions, which occur 24 to 96 hours later, and it's really a T-cell-mediated phenomenon. And so let's talk about each individual types of reactions. Your type 1 or immediate hypersensitivity reaction is IgE-mediated. Your classic examples of this include hives, allergic rhinitis, asthma, food allergies, latex allergy, drug allergies. And you can kind of separate into an acute phase reaction and a late phase reaction. So with your acute phase, it's going to occur minutes to within an hour of exposure. So what happens is the antigen is going to bind to preformed IgE antibodies. So these patients have to be previously sensitized to that antigen already to produce IgE antibodies. Remember that class switching we talked about from IgM as the default antibody to another class? In this case, it's IgE. The IgE, after it's bound to the antigen, binds to receptors on mast cells, and these mast cells degranulate all their products, which include histamines, leukotrienes, prostaglandins, cytokines, and that's what gives you the allergic reaction. So for histamines, your H1 histamines will cause the wheal and flare that you typically see. It can cause bronchoconstriction, leading to wheezing for patients, and it causes the intense pruritus that occurs. Your H2 histamines or receptors are responsible for increased gastric acid secretion. Now there's a late phase after the acute phase, and this can occur anywhere from 3 to 12 hours after the acute phase, and it can last anywhere from hours to days. And what happens in this case is you've got your initial rush or initial mast cell degranulation. That causes other cells to sort of migrate to the area of the reaction. So cells such as eosinophils and basophils, because of the release of cytokines from your mast cells, come into the area, and then they start to release their products. And so now you've got this late phase reaction occurring. The probability of having a late phase reaction really depends on your severity of your acute phase. Kind of makes sense. If your mast cells are really revved up and they've released all their products and they're recruiting a lot of these other cells because of cytokine release, you're more likely to have a lot of these eosinophils and basophils come to the area of the reaction. Your type 2 reactions, your cytotoxic reactions. So what happens in this case is you've got your IgM or your IgG antibodies, and they bind to either fixed tissue antigens or cell receptors. When you have this binding of antibody to your target cell, it causes destruction via either complement activation, opsonation from production of your complement factor C3b, or when the antibody is coating these cells, it can also signal phagocytes to come and attack as well. So examples of your fixed tissue antigen conditions include Goodpasture syndrome. In this case, you've got antibodies that latch on to your basement membrane, causing problems. In myasthenia gravis, for example, these antibodies attach to your acetylcholine receptor in muscles, and so you get myasthenia gravis. Examples of target cell receptors include anything from thrombocytopenia to hemolytic anemias to leukopenia. So any of these cells, receptors on these cells get coated with antibody, and then it gets signaled for destruction. Your type 3 reactions are caused by immune complex deposition. So when you hear about type 3 reactions, really think about vasculitis, okay? These immune complexes form when antibodies combine with antigen to cause these complexes to form, and there's significant precipitation when there's a slight antigen excess. These immune complexes then can precipitate in your small vessels, okay? And when they do, they cause activation of complement, provoking an inflammatory cascade, and you can get necrosis of your blood vessels, which results in a leukoclastic vasculitis. Okay? So sort of your typical animal models for immune complex or type 3 reactions include serum sickness. This results when a large amount of antigen is injected into a non-immunized animal, or your Arthus reaction, which is more of a local reaction, where you have a hyperimmunized animal and then it's given an injection of antigen. So you've already got a lot of circulating antibodies present, and then you've injected a little bit of the antigen, and then you've got these immune complexes form at the local area. So for in the human model, this translates into serum sickness, okay? This occurs for anywhere from 1 to 3 weeks after administration of the drug. Classically, patients will present with fevers, rashes, joint pain, lymphadenopathy, muscle aches, proteinuria. The skin findings are sort of, bless you, universal. You can get these classic serpentiginous rashes on the hands and feet, a lot of itching, but you can also get urticaria, angioedema. And because these immune complexes also form on the joint spaces, you can get arthritis and arthralgias as well too. You can get immune complex deposition in the GI tract, resulting in bloody stools, nausea, vomiting, also immune complex deposition in the glomeruli, causing renal disease as well, or glomerulonephritis as well. So some of the causes of serum sickness include equine anti-tetanus. When we used to use equine, certain antibiotics can provoke serum sickness. Cephalosporin is sort of notorious for causing your type 3 serum sickness reactions, but penicillin can do it as well too. Anti-thymocyte globulin can cause it. Certain monoclonal antibodies like OKT3 and also venom stings as well to your bees and wasps can cause serum sickness as well. Your type 4 reactions or your delayed reactions, these occur 24, 72 hours to even 96 hours later. And it's caused by previously sensitized T cells. When these T cells interact with antigen, you get a response. So some examples of this include contact dermatitis. So for example, if you're walking in the woods and you come across poison ivy and your skin is brushed with poison ivy, about a day or two later you start getting these vesicles and extreme pruritus at the areas where it's exposed to the poison ivy. Another example is with tuberculin hypersensitivity or sensitivity. So this is like your typical PPD injection, right? So for those who've been exposed to TB in the past, well, you've got your already sensitized T cells. And so what do you do when you want to check to see if they've got TB? Well, you inject a little bit of your PPD into their skin. Your macrophages come by, or antigen-presenting cells come by, pick up that PPD, then travel to the local lymph nodes where it interacts with T cells. And if that T cell has already seen tuberculosis, then it causes a localized reaction. So that's when you get the induration that you see with PPD. Okay? So that's your example of your type 4 delayed hypersensitivity reaction. Now, type 5 is an autoimmune stimulatory reaction. So this occurs when you have antibodies that, instead of causing a negative feedback, it actually has a stimulatory feedback. So an example of this includes like Graves' disease, where you have IgG autoantibodies that affect your TSH receptor, causing hyperthyroidism. All right, so anaphylaxis, very, very important topic. It is IgE mediated. Some common causes of anaphylaxis include antibiotics, of course, penicillin being notorious, but any kind of antibiotic can cause this, cephalosporins as well. Foods in children, unfortunately, are common causes of allergic reactions or anaphylaxis. These include your peanuts, tree nuts, shellfish, eggs. Latex are also common causes of anaphylaxis, especially in individuals with spina bifida or in individuals who've had recurrent urinary or manipulation or surgeries. Anesthetic agents can cause anaphylaxis. These include your induction agents, neuromuscular blocking agents, and then finally insect stings are also important causes of anaphylaxis as well. Anaphylactoid, clinically you can't distinguish between anaphylactoid reactions and anaphylaxis reaction. The difference is anaphylactoid reactions are not Ig mediated. They're caused by either direct mast cell degranulation or some other mechanism. So it's a really IgE receptor independent. So examples of this would be like a release of C3a, C4a, and C5a. These are anaphylactoxins that can cause direct mast cell degranulation. Some examples of anaphylactoid reactions clinically include your NSAID reactions, your aspirin reactions, radio contrast media reactions are also considered anaphylactoid reactions, and also sulfite reactions are also considered anaphylactoid reactions because they're not Ig mediated. All right, so both anaphylaxis and anaphylactoid, because they're type 1 reactions, they occur immediately, usually 5 to 30 minutes after antigen exposure. usually get multi-systemic symptoms. More than 90% of the time you have cutaneous symptoms, which include, pruritus, swelling, hives. You can get respiratory symptoms because of bronchoconstriction, like wheezing, shortness of breath. You can have frank cardiac manifestations, like hypotension, for example. You can also get GI manifestations, like abdominal pain, nausea, and vomiting as well, too. With anaphylaxis, you really need 2 organ systems to diagnose anaphylaxis or anaphylactoid reactions, or if you've had just a cardiovascular collapse, and that in and of itself is sufficient to make the diagnosis of anaphylaxis with a precipitating sort of known trigger. How do you treat anaphylaxis? Epi, epi, epi. Don't get fooled by the questions. They'll give you all these other choices. If you have a patient with suspected anaphylaxis, it's epinephrine, 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 okay? There have been multiple documented cases of fatalities from anaphylaxis, and the 2 most common reasons for fatality is failure to recognize anaphylaxis and also failure to give epinephrine early on in the stage of the disease, okay? How much do you give? Well, it's 0.01 milligrams per kilo of a 1 to 1,000 dilution intramuscularly, okay, in the anterolateral thigh. IM seems to work better than sub-Q administration. And what does epinephrine do? Well, it's an alpha and beta adrenergic agonist, so it counteracts all of the physiological abnormalities of anaphylaxis. So with epinephrine, you get bronchial relaxation, you get vasoconstriction, and decreased vascular permeability with epinephrine. What about patients on beta blockers? So beta blockers in and of itself are relatively contraindicated in patients who are at risk for anaphylaxis. So you certainly don't want to give a patient who has a severe bee sting allergy a beta blocker. However, if the patient is already on a beta blocker for whatever reason, cardiovascular, congenital heart disease, whatnot, epinephrine is still the first line. If they're not responsive to epinephrine, then you can use either glucagon or vasopressin, which works on a different mechanism to counteract some of the physiological manifestations of anaphylaxis. So vasopressin can act upon cyclic AMP to counteract some of the problems with anaphylaxis. How do you treat? It's ABCDs, airway, B, breathing, C, circulation, drugs, but always epi is your first line, and then you can assess all the other things later. Remember, steroids don't work until 6 to 8 hours later. I see a lot of people giving that shot of, triamcinolone first. Doesn't work. It takes too long to take effect. You got to give epi first with anaphylaxis. Parental H blockers may help with itching or hives, but really the treatment of choice for anaphylaxis is epinephrine, epinephrine, epinephrine. Right? If they're still not responsive, you may consider volume resuscitation. Remember, there's a lot of capillary permeability. So there's a huge loss of intravascular volume. So you want to replace that volume with volume resuscitation in those patients who may not be responsive. All right, so I'm going to move on to urticaria. Now, urticaria you can sort of divide into acute urticaria or a chronic urticaria. Acute urticaria is defined as hives that last less than 6 weeks. It's IG mediated. Some of the common culprits include foods, drugs, pollens, insect stings. Chronic urticaria is going to occur more than 6 weeks. And by the time it's more than 6 weeks and it's chronic urticaria, the vast majority of it is idiopathic, meaning we don't have an underlying cause. But of that 10% where we do, it may be caused by thyroid disease, autoimmune disease, malignancy, or chronic infection. Now, there's a host of physical urticarias, which are quite interesting in and of themselves. You get a cold urticaria. So a lot of patients who are exposed to cold, for example, they'll develop hives after being exposed to cold weather. And if they're immersed in cold water, they can actually go into shock. So for these patients, I'll tell them you can't go into the ocean. You got to stay in a heated pool, and that's it. How do you test for this? Very simple. You just put an ice cube on their arm. You wait 5 minutes, and they start getting hives right where you put the ice cube on their arm. So it's a cold urticaria. In contrast, you can have cholinergic urticaria or heat urticaria. These patients get hives when it's hot. So they'll tell you, I get hives when I take a hot shower. And so these little hives that occur can be very pruritic and very obtrusive to their normal daily activities. Now, the thing you want to rule out in someone who has, chronic urticaria is that you want to rule out autoimmune disease. So what are some of the red flags of autoimmune disease? Well, if the lesions last more than 24 hours in a fixed location, then that's sort of a red flag. And I'm not saying, hives that start off in one area and then move to another. It's hives that stay permanent in one particular area for more than 24 hours. That's a red flag. Because a lot of the acute hives or chronic hives, they'll still be there after a few days, but they move to different locations, okay? Now, if they leave any residual markings, right, like ecchymosis or purpura, that's another red flag, okay? And if they have other symptoms besides just being pruritic, if they're burning sensation, really, really tender, that's another red flag. And then, of course, finally, if they've got like constitutional symptoms like weight loss, fever, malaise, fatigue, and frank arthritis, that's very concerning for urticarial vasculitis. How do you make the diagnosis? Well, you do a skin biopsy, and then you can document the vasculitis. Some labs you can do. Some of these patients will have decreased C3 or C4 levels, and also antibodies to C1q. All right, I'm going to just spend a few minutes on asthma. Like I said, Dr. Jones is going to talk to you a lot more about asthma, but as an allergist, I really wanted to talk to you about asthma. Asthma is really defined as a chronic inflammatory disorder, and it's characterized by reversible airflow obstruction with the cardinal symptoms of cough, chest tightness, wheezing, and shortness of breath. Now, the 2007 AEPP guidelines are over 400 pages, which basically doesn't allow anybody to read it because it's way, way, way too long. So I'll kind of summarize the guidelines, okay? So basically, in order to establish control, you use the rule of twos. And control is defined as the degree in which the manifestations of asthma are minimized and the goals of therapy are met, meaning that you have minimal side effects with adequate control. And you want to assess for impairment, right? So what does impairment mean? Well, it's symptom frequency. How often are they having their symptoms? So a nice rule of thumb is the rule of twos. If you've got less than 2 times per day per week, less than 2 times nightly symptoms per month, or you're needing to use the albuterol less than 2 times per week, then your asthma is considered under control. Now, there's also another domain called risk. And basically what it says is if you've had a previous risk, you're more likely to have a future risk. So any patient who's been to the emergency room or been hospitalized for more than 2 times within the past year, they're more likely to be hospitalized or come to the ED for their asthma. So for any of those patients who have more than 2 ED visits or hospitalizations for asthma, then their asthma is not under control and you need to step up therapy. How do you treat? You guys do this every day. You guys all know this. You got relievers and controllers. I won't go over this in too much detail. Your inhaled corticosteroids are sort of your gold standard. For those patients who, or parents who are sort of steroid phobic, leukotriene receptor antagonist are options that are available, but they're not the gold standard. And then for severe cases, you would add on a long-acting beta agonist like formoterol or salmeterol. Now, these long-acting beta agonists, of course, should always be used with an inhaled corticosteroid. Right. So, a lot of parents come in and ask me, my child is wheezing. Does he have asthma? And their kid's like, 2 or 3 years old. What do you tell them? Before, we really didn't know. And it's very difficult, actually, to make the diagnosis of asthma in a young child because the symptoms of asthma are very, there's a lot of variability in young children, okay? In addition to that, a lot of young children wheeze. Up to 40% of children under 5 years of age wheeze at some point in their life. So wheezing in itself is not always due to asthma. As you know, not all that wheezes is asthma. You can get virus infections, you can get bronchiolitis, and these children don't necessarily develop asthma or have asthma. So they came up with something called the Asthma Predictive Index. So what it says is for young children, less than 3 years of age, who have more than 4 episodes of wheezing, you can use this sort of asthma predictive index to see what's their likelihood of having asthma when they're 6 years of age. So if you've got 1 major criteria or 2 minor criteria present, then there's a 76% chance that the child will have asthma by the time they're 6 years of age. Okay? So what's the criteria? Well, the major criteria is any of their parents have asthma, or if the child has eczema, okay, that's a major criteria. So any one of those, and you've got 4 episodes of wheezing, then 76% chance of having asthma when they're 6 years old. If you've got 2 minor criteria, like if the child has allergic rhinitis, wheezing apart from colds, or eosinophilia, all right, then that child, again, has a high risk of developing asthma when they're older. Okay, so this is very helpful because, you can't do any kind of objective measures of lung function in a 3 or 4 year old. It's impossible to do. So this kind of helps us get a sense of when we need to start controller therapies for these young children. All right. So moving on to rhinitis, there's allergic rhinitis, non-allergic rhinitis. So your allergic rhinitis includes your seasonal, perennial, or perennial with seasonal exacerbations. You've got something called non-allergic rhinitis with eosinophilia syndrome or Nery's syndrome. You've got vasomotor rhinitis, and then you've got rhinitis medicamentosa, which I'll talk about. So your allergic rhinitis can be seasonal, and these can be due to different grasses, trees, weeds, and pollens. You've got your perennial types or year-round type, which include allergy to dust mites, molds, animal dander. Patients complain of congestion, rhinorrhea, sneezing, nasoporitis, and all this is IgE-mediated. If you do a nasal smear, you'll see some eosinophils in the nasal smear. Physical examination, you'll see the Denny Morgan lines or the wrinkles underneath the eyes, your allergic shiners, the dark circles due to venous congestion. We'll have that nasal salute, this constantly going like this, so now they've got this ridge across their nose. Okay. If you do your physical examination, the mucosa will be pale and swollen. Look in the back of their throat, you can have some cobblestoning in the back due to postnasal drip. If you do see nasal polyps in the child, think about another entity, not allergic rhinitis. Think about cystic fibrosis or think about allergic fungal sinusitis because it's not common to have nasal polyps in children. What do you do for patients with allergic rhinitis? Well, the 3 A's, avoidance. Okay, for us, we do skin testing or blood testing to see what they're allergic to and then try to avoid what they're allergic to. Antihistamines are considered first-line therapy, but intranasal steroids are more effective. And then finally, we have allergy shots or allergen-specific immunotherapy for patients who are severely allergic. What do you tell them to avoid? Well, pollen avoidance. The tree pollens are highest in the springtime. Grasses are in the summer, weeds in the fall. So if you know exactly what they're allergic to, then you can tell them to close the windows, get an air filter in their homes during the periods that they are allergic. If they've got dust mite allergy, you want to talk about mattress and pillow encasings. Wash their sheets in 140 degrees of hot water at least once a week and decrease the humidity by less than 50% because dust mites really thrive in high humidity environments. If they're allergic to dog or cat, you want to kind of talk about removal of the pet, but usually in my experience, they're more likely to get rid of me than to their pets. So I kind of just walk a really fine line on eggshells. I said, maybe you want to get rid of the dog or cat, but if you can't, at least keep the dog or the cat outside of the bedroom, okay? An air filter will help with removing some of the dog and cat dander, and also washing the pet frequently every week helps as well too. And there's no such thing, by the way, of a hypoallergenic dog or cat. It just doesn't exist. It's just a marketing scheme. All right, so antihistamines, all right, is the treatment for allergies. Now, some of the early antihistamines like diphenhydramine or chlorpheniramine can cause sedation. This is because they cross the blood-brain barrier. It can interact with dopamine, serotonin, and acetylcholine receptors in the brain. So some of the patients can complain of blurry vision and dry mouth. Now, ironically, for some young children, diphenhydramine doesn't make them more sleepy. It makes them more hyperactive, actually. So you can get a paradoxical effect of diphenhydramine for some young children. The second generation antihistamines are less likely to cross the blood-brain barrier. So these include your cetirizines, your fexofenadines, and loratadines, and they cause little to no sedation. Fexofenadine in particular doesn't cross the blood-brain barrier, so there's no potential for sedation with fexofenadine. Allergen immunotherapy or allergy shots, all right. This only works for IgE-mediated conditions. So what do as allergists? We give increasing doses of the allergen to your patients to induce an immune tolerance. And how does this work? Remember we talked about T regulatory cells? So it really increases the number of T regulatory cells, and these T cells produce the IL-10 and TGF-beta, that immune speak, for suppress the immune system. And then it also causes blocking Ig antibodies to IgE to really suppress the immune response. Right. NARIs, or non-allergic rhinitis with eosinophilia syndrome. These patients will complain predominantly of chronic nasal congestion. The nasal smear shows eosinophilia, but when you do testing for them, whether it be with skin testing or blood testing, it's all negative. Vasomotor rhinitis, this is due to neurogenic or vagal stimuli. A lot of patients will complain of sneezing on exposure to cold or certain spicy foods, or even sunlight, for example. So examples of this include like skier's nose or gustatory rhinitis when they eat certain foods. It's not an allergic reaction. It's more of a vagal neurogenic stimuli reaction. Rhinitis medicamentosa occurs when patients overuse vasoconstricting nasal drops like phenylephrine or nafzolin. So they continue using it and become tolerant of it, and they need more and more of it. And when they stop using it, they get increased or rebound nasal congestion. So it's a lot of times very difficult to get patients off of this. All right, so now I'm going to touch upon atopic dermatitis. It's something that you guys probably see all the time. It's defined as a chronically relapsing inflammatory skin disease that's associated with allergy. It's the itch that rashes, so it's very, very itchy. So if you have a child that has a rash that's not itchy, it's not atopic dermatitis. It's by definition very, very, very pruritic. There's something called the atopic march, where 50% of patients with AD will develop asthma and allergies later on in life. So it starts off with AD and then allergic rhinitis and then proceeds to asthma. Some of the major features, like I mentioned, include pruritus. It's a chronic and relapsing course, so it gets better, it gets worse. A typical distribution in young children is usually on the cheeks and face and then in extensor surfaces. And in the older children and the adults, and it's more flexural involvement. But these are not hard and fast rules. You can have sort of differences. There's usually a personal or family history of atopic disease. How do you treat? I put up this sort of pyramid on what to do. The thing that you really want to emphasize for these patients is to moisturize, moisturize, moisturize. We're learning that atopic dermatitis is really a skin barrier problem. So you really got to tell your patients that they've got to moisturize. No matter what you do with other things, if their skin is not moisturized and it's cracked, you've got exposure to all these allergens or irritants into the skin, it's not going to get better until you heal the skin barrier. Okay? We see that it's really a problem with transepidermal water loss, and that's why it's a skin barrier problem. In these patients, there's a lot of evaporation and water loss going on. The water content in the skin is significantly decreased, so you really got to enforce moisturization for your patients with emollients. Second on the pyramid scheme are immunosuppressants. Topical corticosteroids are sort of the mainstay of treatment. In terms of bioavailability, lotions are more bioavailable than creams, and creams are more bioavailable than lotions. But lotions can be drying sometimes, and then ointments can also be too occlusive in times. So in the summertime, excessive heat can cause occlusion and result in itching and folliculitis. So some creams may be better during times when it's really hot like it is now. Calcineurin inhibitors like tacrolimus and pimecrolimus, right? These bind to FK506, which cause a signal inhibition, signal transduction inhibition of some of the pro-inflammatory cytokines, and both are very useful for patients with AD, especially for parents who are steroid phobic, and both are approved down to 2 years of age. Antihistamines, you really want to break that scratch, itch, scratch cycle, because the more they scratch, the more the skin gets inflamed, the more itchy it gets, and you kind of run through this kind of perpetual cycle. So a lot of times you can use both H1 and H2 blockers. Now, our H2 blockers like ranitidine and famotidine, about 15% of your histamine receptors are H2 on your skin. So by blocking both, you block both your H1 and H2 receptors on your skin, and that can be of value. You want to avoid topical antihistamines because they can cause sensitization. Because your skin is already inflamed, now you're putting topically there, they can develop an allergic reaction to your topical antihistamines. If that fails, consider wet wraps in patients with severe atopic dermatitis. These wet wraps or dressings reduce the pruritus and the inflammation by cooling the skin. They also act as a nice barrier at night as well, too, to prevent the child from continuously scratching their skin off. And also improves the penetration of topical steroids and topical calcineurin inhibitors as well. Antibiotics. The role of antibiotics is really as sort of a last resort. Now, there's some studies that show that in patients who have severe atopic dermatitis, their skin is colonized by Staph aureus. When they looked at these patients of AD, about 90% of those patients harbored this Staph aureus. And of those patients, about 50% of those patients that harbor the Staph aureus also produce this enterotoxin called TSST1. And this enterotoxin can cause inflammation on the skin, causing worsening of the atopic dermatitis. So for those severe patients, you can also consider a short course of antibiotics to treat for Staph aureus. I wouldn't recommend it as first-line therapy, but if you've already done the steroid, you've already done the moisturization, the wet wraps, and then the child still has pretty bad atopic dermatitis, then steroids might be an option. Typically, you can use semi-synthetic penicillins or first-generation cephalosporins are effective. Topical antibiotics can be useful, but it's kind of difficult to do if it's kind of widespread. What you don't want to do is do maintenance therapy with antibiotics, and then now you're at risk for MRSA colonization. Okay. Now, food allergies. So a few years ago, if I had this talk, I would probably say that it affects about 4% of children. Actually, probably like 10 years ago. And then about 5 years ago, it'd be about 6%. Now it's about 8%. So each year we're seeing an increase in food allergies and allergic diseases in general. Now, food allergies are the leading cause of anaphylaxis outside of hospitals. It's very common in the atopic dermatitis population. About a third of patients with atopic dermatitis will also have food allergies as well. So what are the common food allergens? Well, in children, 85% of them will have allergies to either wheat, egg, milk and soy, peanuts and tree nuts, or seafood. Okay. How do you make the diagnosis? Well, you want to make sure the history is consistent with a type 1 immediate hypersensitivity reaction. Right? If mom tells you, well, Johnny gets a stomach ache and some abdominal pain and diarrhea after drinking milk, like 8 hours after drinking milk, that's not a food allergy. That's a lactose intolerance. Okay, he doesn't have any skin manifestation, doesn't have any pruritus, doesn't have any hives. That's going to be an intolerance rather than a true food allergy. So the history is very, very important. And then you want to confirm it with a allergy test, whether it be the skin test or a blood test, which is called RAST. The skin test has a very good negative predictive value. So if the skin test is negative, it's more than 95% chance that the child is not allergic to that particular food. However, a positive test is not very helpful because it has very low specificity. It's only about 50%. So if a child has a positive skin test, it's only a 50% chance that the child has an allergic reaction to that food. So that's why it's really important to elicit the history, because you want to collaborate the clinical history with the skin test findings. And that's why we don't test everybody for food allergies, because you get a lot of false positives with the skin test. Now, the allergy blood test is less sensitive than the skin test, but it has its own problems as well, too, because, again, it has very low specificity. Okay? Now, there are certain cutoffs that people have used to determine the positive predictive value for a clinical response. And this is not for you guys to kind of memorize or anything, but just kind of to show you, at certain levels, and unfortunately, we only have it available for 4 different types of foods, the positive predictive value is quite high. So, for example, if a child has an egg level of 7 or more, there's a 96 to 98% positive predictive value that that child is allergic to egg. Right? What happens when it's kind of intermediate? What happens when it's like 2 or 3? Well, can't really tell you. It's going to be like 50%. So that's why, again, it's really important to collaborate the clinical history with the results of your test. How do you make the diagnosis? Well, the gold standard is a double-blind, placebo-controlled food challenge. Well, unfortunately, that's usually used in research studies and whatnot. There's just not enough time and staffing to do that, and most parents don't want to do that. So really, you have a clinical history that's compatible with a food allergy. You confirm it with either allergy skin testing or blood testing, and then the treatment really is avoidance, avoidance, avoidance. If the child develop a anaphylactic reaction or more systemic reaction to the food, or if it's a high-risk food like tree nuts, peanuts, shellfish, you want to prescribe an epinephrine pen. So a lot of parents are going to ask you, is my child going to outgrow this milk allergy, or is my child going to outgrow my peanut allergy? Well, fortunately, for children with milk allergy, egg allergy, soy allergy, or wheat allergy, 85% of children will eventually outgrow it. Okay? Unfortunately, for things like peanuts, tree nuts, and seafood, only about 20% of those kids are going to outgrow those specific food allergies. All right, now we're going to move on to adverse drug reactions. The World Health Organization defines adverse drug reactions as any noxious, unintended, or undesired effect of a drug that's used for prevention, diagnosis, or treatment. Cutaneous or skin manifestations are most important. About 15% of patients will have adverse drug reactions during their hospital stay. About 7% will have serious reactions. Now, under the umbrella of drug reactions, you've got different types. between type A reactions, type B reactions, intolerances, idiosyncratic and allergic reactions. My primary focus is going to be on your allergic reaction in the interest of time. So your type 1 reactions, we talked about the gel and Coombs already. It's going to be immediate. It's going to be right away. It's going to be a few minutes to hours, okay, and it's IG mediated, all right? So there's cross-linking of these preformed IG antibodies present, and it causes release of mediators on your mast cells. So you're going to have like hives, difficulty breathing, anaphylaxis. Penicillin is a really good example of this. It acts as a hapten. What is a hapten? Well, a hapten basically is a chemically reactive small molecule. Immunologically, it's not reactive. So by in it itself, it can't activate the immune system. However, it can undergo covalent bonding to self-peptides, and now when it undergoes covalent bonding, it's a much bigger molecule, and it's able to be recognized by the immune system to cause a reaction. Right. Your type 2 reactions, your cytotoxic reactions, these occur days after the drug is administered. So, for example, your IgG and IgM antibodies then can recognize the drug antigen on cell membranes, causing other cells to come in and destroy that cell. Your drug-induced hemolytic anemias and thrombocytopenias are examples of cytotoxic type 2 reactions. A lot of medications can do this, including methodopa, penicillins, and cephalosporins as well, too. Your type 3 reactions occur 1 to 3 weeks later. Remember, it's immune complex mediated, so think about vasculitis. These immune complexes deposit in the blood vessel walls, hence the vasculitis. They can also deposit in your glomeruli, causing glomerulonephritis, your joint spaces, causing arthralgias and arthritis. Patients can get fevers, lymphadenopathy, rashes. Examples of this include ATG, thiouracils, phenytoin. All of these things can give you what we talked about in terms of serum sickness. Your delayed type reactions, or your type 4 reactions, these occurred by way of previously sensitized T cells, and it's delayed. It occurs, anywhere from 24 to 96 hours later, although here it says 48 to 72 hours. That's your typical time, 48 to 72 hours. An example of this would be your contact dermatitis from, say, topical antibiotics. So neomycin is very common in terms of causing this delayed type hypersensitive reaction for individuals. Local anesthetics can do it, and topical antihistamines can do it as well too. That's why when the skin is inflamed in patients with atopic dermatitis, you want to avoid the topical antihistamines because of this reaction. Insect allergy. So about 1% of children will have systemic reaction to insect stings. Some of the most common ones are from your bees, yellow jackets, hornets, wasps, and ants. If the child has had a previous systemic reaction, there's about a 10 to 15% chance of a future systemic reaction. Allergy shots for venom are about 98% effective in preventing future systemic reactions. So where are these things found? Well, hornets are really found in nests outside of trees. Bees are found inside of trees. Wasps are usually found on the eaves of like the roofs and whatnot. Yellow jackets kind of are lower in bushes and cracks of old buildings, and fire ants are kind of are found in the mounds of dirt. So there was a researcher who looked at, what are your chances of developing a future reaction? So if a child has had no reaction, okay, or adult has had no reaction, if they're stung by a bee, there's about a 17% chance that they'll develop a reaction. All right? If you've got a large local reaction, just a local reaction, then it's only 10% chance. So actually, if you've got a large local reaction, it's protective versus the general population. For a child, if you've got a systemic reaction, it's about 10%. So it's still less than the general population. However, if the child had anaphylaxis, if the child is stung again by a bee down the road 10 years later, there's about a 40% chance that the child is going to have a systemic reaction. So, who gets immunotherapy and who should get treated or checked? Well, because the only increased risk is a child with anaphylaxis, that's the only child that you would test or treat with immunotherapy. Because if a child has just a systemic reaction, then there's not an increased risk versus the general population. Does that sort of make sense? Yeah? Okay. All right. So for management, you only refer to allergy if a child has had anaphylaxis to an insect sting. Okay, large local reactions or generalized systemic reactions without anaphylaxis don't really require any workup because you're not going to do anything about it. Okay, because their risk is actually lower than the general population of developing a systemic reaction in the future. Now, latex allergy. Natural rubber latex is made from the hevea tree. It's a frequent cause of anaphylaxis in children who have spina bifida or who've had some sort of genital urinary surgeries and whatnot in the past. And it's really due to IgE-mediated sensitization to the hevea protein. There's cross-reactivity with multiple fruits and vegetables, including papaya, kiwi, bananas, figs, potatoes, avocados, tomatoes, and chestnuts. Now, mastocytosis. All right, mastocytosis is a rare disorder where you have abnormal mast cell proliferation, and the degree of involvement really depends on the extent of the disease. If you've got just cutaneous involvement of mast cells, then it's just urticaria pigmentosa. If you've got systemic mast cells, it's more of a systemic phenomenon. If you've got monoclonal mast cells, it's malignancy. So urticaria pigmentosa is increased mast cells just in the skin. You have what's called a Derriere sign. So you've got these little brownish macules, and stroking the macule causes a wheal formation. That's your positive Derriere sign. It's pathognomonic for urticaria pigmentosa. You can check a tryptase level, and usually it's more than 20. Systemic mastocytosis is much more severe. You've got mast cells pretty much everywhere, and sometimes in your GI tract and your liver. So patients can complain of abdominal pain, fatigue, and they're really prone to anaphylaxis because now you've got all these mast cells all over the place, and they're ready to discharge all of their mediators to cause a reaction. Malignant mastocytosis is usually pretty severe. They've got all the constitutional symptoms, and then also they've got hepatosplenomegaly, lymphadenopathy. How do you treat mastocytosis? Well, you want to avoid things that can directly or indirectly affect mast cells, avoiding extremes of cold or extremes of heat, alcohol, aspirin, opiates. Oral cromolyn can stabilize mast cells if they have a lot of GI symptoms. And for malignant mastocytosis, unfortunately, nothing really helps. Various chemotherapeutic agents have been used, but most of them have not been very successful, unfortunately. All right, so how do you prevent allergies? A lot of your patients may ask you this. Now, especially if they're considering having another child, if the older sibling has allergies, what can I do to prevent my younger child from having allergies? Well, what helps? Well, breast is always best. It's always the recommendation of AAP. It's a recommendation for preventing allergies, and breastfeeding for at least 4 months seems to help with prevention of allergies. For high-risk infants who are not breastfed, the key is not breastfed, then hydrolyzed formulas may help in the prevention of allergies in the future. What does not help? Well, any maternal restrictions during pregnancy, right? So they don't have to avoid peanuts or shellfish when they're pregnant, the mom in any case. And then we used to say that you should delay the introduction of solids until later. Turns out that's not true. There's really not any evidence to support that. So you tell them just introduce everything by 4 to 6 months. And in fact, there's a lot of literature that shows that if you introduce these allergenic foods earlier, you can actually prevent the development of allergic disease. Okay? And then soy-based formulas doesn't really help as well. All right, so let's go on to some questions. Right, a 17-year-old boy has recurrent episodes of angioedema without urticaria. Previous treatment with epinephrine and steroids has had little effect. What workup should be done at this point to work up his condition? Should we get A, C1 inhibitor level and function, B, mannose binding lectin level and function, C, C6 level, or D, skin testing to pollens? . All right, very good. So most of you got the answer right. The answer is A. The patient has classic symptoms of hereditary angioedema, and so you want to check for C1 esterase inhibitor function and level as well. All right. Next question. A 15-year-old girl is given a new medication for seizures. About 2 weeks after starting her medication, she began having urticaria, fever, arthralgias, and malaise. What category of hypersensitivity reaction does her reaction fall into? Is it type 1, 2, 3, or 4? Very good. Most of you got it right. The answer is type 3. It's immune complex mediated. It's serum sickness is what's occurring. So that's the answer. Okay. A 5-year-old boy with a history of a cardiac condition and a peanut allergy presents for wild child care. After eating a candy bar, he starts to develop hives and throat tightness. Mom informs you that he is also taking carvedilol and digoxin. What is the next most appropriate step? Should you A, discontinue the carvedilol, B, give him diphenhydramine, C, intramuscular epinephrine, or D, intramuscular glucagon? Okay, very good. Everybody got it right. Epinephrine, right? Carvedilol, discontinue it, won't help acutely for his symptoms, okay? You want to give him epi, and even though he's on the beta blocker, epinephrine is the first choice, and only if it's refractory to epinephrine would you consider an alternative agent like glucagon. Question number 9. 2 weeks ago, a 16-year-old boy went to his physician for cough, sore throat, runny nose. On physical examination, he had a fever of 101, mild pharyngeal erythema, and a small lymph nodes bilateral on his neck. His physician prescribed him with amoxicillin for 2 weeks. After 7 days, he develops a morbilliform rash. What should be done next? A, reassurance. B, tell him he's allergic to amoxicillin and to avoid it in the future. C, tell him he's allergic to all penicillin family drugs and to avoid them in the future. D, tell him he's allergic to penicillin and to also avoid cephalosporins because of cross-reactivity. Very good. Reassurance. So this child most likely had EBV or mono. And there's an association with giving amoxicillin and EBV, and almost 100% of these patients will get a rash due to amoxicillin. It's due to cross-reactivity between amoxicillin and the EBV, and it's not really due to actual amoxicillin allergy. So very good. So all you need is just reassurance. Okay. Question 10. A 2-year-old boy presents with a history of recurrent abdominal pain, vomiting, flushing, generalized red-brownish macules. He has had also several hospitalizations for anaphylaxis. Which of the following tests would most likely yield the diagnosis? A, skin testing, B, tryptase level, C, C1 esterase inhibitor function, or D, IgE level? Okay, so most of you got it right, some didn't, but the answer is correct is B. It's tryptase level. Okay, this child has mastocytosis or urticaria pigmentosa, and that's why he's having the recurrent episodes of anaphylaxis. That gentle stroking of the macule causes induration, which is Derriere sign, so you want to confirm it with a tryptase level, and the tryptase level will be high in these patients. So the correct answer is B. A 5-year-old boy with spina bifida has multiple surgical procedures on his urinary tract and subsequently developed a severe latex allergy. What is the most likely food he may be allergic to due to cross-reactivity with latex? Is it A, peach? Is it B, pear? Is it C, potato? Is it D, carrot? Very good. Potato is the correct answer. Potato. That's the cross-reactivity of latex. Potatoes, papaya, those are cross-reactive with latex. In addition, kiwi, avocado as well too, and bananas. All right, number 12. A 4-month-old girl is seen by you for the first time. On exam, you notice that the umbilical cord is still attached. The baby has severe gingivitis and has several abscesses on the gluteal area. What test would most likely yield the diagnosis? Is it A, dihydrorhodamine test? Is it B, nitroblue-tetrazolium test? Is it C, flow cytometry for CD40? Is it D, flow cytometry for CD18? Oh, we're all over the place. Okay. All right, we need to spend some time on this question. Okay. So let's go back. Let's go back to see what's going on here. Okay, so you've got this 4-month-old girl, all right, you're seeing for the first time in your clinic, and the umbilical cord is still attached. So this delayed separation of the umbilical cord, the baby has severe gingivitis and abscesses in the gluteal area. Okay, so which test would you yield the diagnosis? Well, you've got delayed separation of the umbilical cord, recurrent abscesses, and gingivitis. So what you really should be thinking about is your leukocyte adhesion defect, right? So the test for that is going to be your flow cytometry for CD18. All right, so that's the answer is correct, is D. What about A? Dihydrorhodamine test, that's for what? Yeah, chronic granulomatous disease. Now, A and B can both diagnose chronic granulomatous disease. So by process of elimination, you can, if you knew that, then you can eliminate A and B. All right, and then remember that most cases of chronic granulomatous disease occurs in boys. This is a girl. 70% of them occurs in boys. So the boards are not going to try to trick you. They're going to try to help you. So that putting in girl tells you it's probably not going to be CGD. All right. How about CD40? Or CD40, what does that occur in? It can occur in hyper IgM syndrome, right? The CD40 ligand and also CD40. So that's not going to be your answer. So the correct answer is CD18, leukocyte adhesion defect. Okay. I know that's a tough question. Okay. All right, next question. An 18-month-old boy is diagnosed with severe Epstein-Barr virus 4 months ago. The boy returns with, in 4 months with fever, diffuse lymphadenopathy, weight loss, fatigue, and malaise. What is the most likely diagnosis? Is it A, ataxia-telangiectasia? Is it B, X-linked lymphoproliferative syndrome? C, Wiskott-Aldrich syndrome? Or is it D, autoimmune lymphoproliferative syndrome? Okay, we need to spend a few moments on this one as well. Okay, let's go back. You guys are doing so well. You're tired, I understand. Okay. Okay. I'm moving too fast? Okay, I'm sorry. Okay, I'll give you, okay, so I will try this again. All right, so 18-month-old boy diagnosed with Epstein-Barr virus, hepatitis 4 months ago, comes back with fever, diffuse lymphadenopathy, weight loss, fatigue, and malaise. Remember? Duncan syndrome, all right? So hepatitis with EBV, they come back with monoclonal proliferation of B cells resulting in leukemia, lymphoma. So that's the correct answer. Is D, autoimmune, X-linked lymphoproliferative syndrome. B. I'm getting tired too, sorry, I understand. B, so X-linked lymphoproliferative syndrome. Okay. So that is the answer B. All right, so I'll give you more time. Question 14. A 15-month-old boy with history of eczema, thrombocytopenia, and recurrent infections is seen by you for routine child care. What vaccinations would be most appropriate at this time? Is it A, MMR, B, varicella, C, live intranasal influenza, D, DTaP, or E, OPV? A little bit of time. There you go. Okay, great. You guys are back to your form. Very good, very good. So what this question is asking is which one are the live vaccines that you should not give for patients with immunodeficiency, and D is the correct answer. DTaP is the correct answer. That's not a live vaccine. Very good. All right. All right, number 15. A 3-year-old boy presents with urinary retention. He has a history of recurrent skin and organ abscesses that grow out for Buccodaria species. Right, so these organ abscesses, Buccodaria species, all right, and urinary retention. Which of the following tests would most likely yield the diagnosis? Is it A, flow cytometry for CD18, C, dihydrorhodamine test? Is it C, peripheral smear showing giant granules, or is it D, genetic analysis showing STAT3 mutation? A little more time to think, and I'll press it. Okay, very good. Most of you got it right. It's the dihydrorhodamine test. All right, so the patient has chronic granulomatous disease, right? Has got the Buccodaria. So the correct answer is B, dihydrorhodamine test. Okay. Okay, good. And number 16. A 10-month-old infant is seen by you for evaluation of neutropenia. Her absolute neutrophil count is 400. You check her absolute neutrophil count. You had checked her absolute neutrophil count 3 weeks later, and it rises to 2,000. She has a history of Pseudomonas sepsis. At the time of her infection, her absolute neutrophil count was documented at 400. Give you a little time to think about that one. And then what is the most likely diagnosis? Is it A, Kosman syndrome? Is it B, cyclic neutropenia? Is it C, severe chronic neutropenia? Or is it D, HIV? Give some time. There we go. Okay, very good. Cyclic neutropenia. So she gets her nadir, okay, every 3 to 6 weeks, and when she gets her nadir, she's prone to sort of opportunistic infections like Pseudomonas. So the correct answer is B, cyclic neutropenia. Very good. All right. So number 17. I promise we only got a few more to go. Number 17. 16-year-old girl presents with hives for the past 4 months. She complains of joint pain, general malaise, that's really not associated with heat or cold exposure. On physical examination, there's erythematous wheals on her extremities and abdomen with areas of hyperpigmentation and ecchymosis. Give you a few seconds, think about it. And then what is the most likely diagnosis? Is it A, chronic idiopathic urticaria? Is it B, hereditary angioedema urticaria? Is it C, urticarial vasculitis? Is it D, familial cold urticaria? Give you a few seconds to think about it, and then I'll press this. Okay, we need to discuss this a little bit more detail. All right, let's go back. Some chose A, some chose C. Okay, so let's go back to the vignette. So she's got these hives for 4 months, right? But she's got joint pain. She's got malaise, okay? So those are sort of red flags that this is just not your run-of-the-mill chronic idiopathic urticaria. And then when you examine her, she's actually got ecchymosis on the physical findings. So again, this is not going to be your run-of-the-mill chronic idiopathic urticaria. This is going to be something like urticarial vasculitis. So that's what you're going to be concerned about. So she definitely has the red flag. So the answer is urticarial vasculitis. Your idiopathic chronic urticaria is not going to give you all these constitutional symptoms and certainly is not going to cause ecchymosis on the skin. Okay, so the answer there is C, urticarial vasculitis. Okay, question 18. A 14-year-old boy with asthma reports having cough 3 days per week, for which he uses albuterol with relief. He has 3 nighttime awakenings per month because of difficulty breathing. He's currently on a low-dose inhaled corticosteroid and reports adherence to his medications. What is the most appropriate next step? So I give you a little bit of time to kind of absorb the question. And then the question is, what is the most appropriate next step? Should you A, recommend continuing on the low-dose inhaled corticosteroid? B, discontinue the low-dose inhaled corticosteroid and use albuterol only as needed? C, change to a medium-dose inhaled corticosteroid? Or D, add a leukotriene receptor antagonist and continue the low-dose inhaled corticosteroid? Give you a few seconds to think about it. Okay. An answer. Okay, most of you, where are we? C. Okay, most of you've got it right, all right? So obviously his asthma is not well controlled. I think all of us kind of know that, right? He's got multiple nighttime awakenings. His daily symptoms are not well controlled. The question is, what's the next step? Well, remember I said inhaled corticosteroids are the preferred agent. So in that age group, going from a low-dose inhaled corticosteroid to a medium-dose inhaled corticosteroid is the most appropriate step. Adding on a leukotriene receptor antagonist isn't necessarily wrong, but it's not the preferred treatment. So only if the parents, for whatever reason don't want to do that, then it is an alternative treatment modality, but really upping the dose of the inhaled corticosteroid is the most appropriate step. Okay. Number 19, a 4-year-old developmentally delayed girl with silvery hair and hypopigmentation of the skin presents with frequent respiratory tract infections. What finding on a routine blood smear would be consistent with the diagnosis? Is it A, small platelets? Is it B, giant granules? Is it C, absence of color change of nitro-blue tetrazolium dye? Or is it D, pronounced leukocytosis, white count above 50,000? Give you a few moments to kind of digest that and answer. Very good. So giant granules are the answer. This child has Shiria Kagashi, the member of the oculocutaneous albinism, recurrent infections, and now you've got these giant granules, which really kind of seals the diagnosis. Okay. All right, so last one. Number 20, a newborn comes to your office for a well baby visit. All right, the parents are really concerned because there's a strong family history of atopic disease. They would like to know how they can prevent the development of allergies in their newborn. So what do you do? All right. So according to the 2008 AAP guidelines, which of the following should you recommend? Should you say A, the parents should delay the introduction of highly allergenic foods until after 12 months of age? Is it B, the parents should exclusively breastfeed the infant until at least 4 months of age? Is it C, the infant should be fed on a soy-based infant formula to decrease the risk of cow milk protein allergy? Or is it D, whether the infant develops atopic disease depends on what the mother ate during her pregnancy, so it's just too late. I'm sorry, nothing I can do. All right? So give you a few moments to kind of digest all that, and like 5 seconds or so, and then you can answer the question. Very good. Yay. All right. So breastfeeding is best. Breast is best. Very good. B is the correct choice. Thank you, everybody, for your attention. Good luck on your exam. You guys will do great. All right. Thank you.